As you will recall, on Monday we laid out for you many of the general concepts about neoplasia, benign and malignant. And today, what I want to do for the most part is finish up your introduction to neoplasms by giving you a kind of a rapid kaleidoscopic picture show of a variety of benign and malignant tumors so that you can appreciate how they might present clinically, just a teaser really, and kind of the broad array of things that can happen, and to give you a beginning handle on nomenclature of neoplasms. So that's the goal for today. But before I get on to that, I think we ought to ask the question, so it doesn't get lost, is, okay, we got a lump of cells, benign or malignant. What difference does that make to the host? In other words, what is the impact of, generically speaking, what is the impact of neoplasm on the host? And this outline is a good way to go at it. Let's take perfectly benign neoplasms. They're not invasive, they're not metastatic. Question is, well, you got a benign neoplasm, what can it do to the host? Well, most of the effects are going to be local. I mean, if you think of the cartoon that I showed you, it's just like an expanding balloon locally in some area, and you'd predict that the first thing that a benign neoplasm to do is produce some local mechanical effects. Now, these vary from trivial to lethal. If you had a marble-sized benign neoplasm in one of your love handles here, there'd be a couple of you in the world that would know about it. Maybe a few more than that, but at any rate, it would be trivial. On the other hand, it could be of cosmetic importance. You wouldn't want a benign neoplasm the size of a walnut on the tip of your nose. Biologically not terribly threatening, but bad anyway. I mentioned lethal. This is something to keep your eye on. You can die of a benign neoplasm. It sounds like an oxymoron, but think of an expanding benign neoplasm in the confines of the cranial cavity. There's no room in there, and as it starts growing, it's going to sooner or later press on something vital in the brain, and it could produce, if it's not interrupted, could produce death. So benign neoplasms can kill, generally by something going on mechanically. Benign neoplasm, as it's expanding locally, again, you think just of that cartoon, it's going to press on adjacent structures as it expands, and it may destroy adjacent structures just by sitting on them and knock off the function of one tissue or another. So that can be quite significant. And that's all based on just the expansion of the benign neoplasm. Now, I've mentioned local complications here. These are sort of secondary things that may occur, and they may be very important. A benign neoplasm growing under a surface may expand to the point where the surface ulcerates over. Then there may be hemorrhage. Could be trivial, could be lethal, but there could be hemorrhage from such an ulcerated area, or there might be infection. These are sort of secondary complications of the local mechanical situation. Another thing is the benign neoplasm can plug the plumbing. It's in the wall of a duct or pressing on a vessel or something of that sort. It can produce obstruction that's very significant. These are all sort of local effects. There's one sort of exception to this, and I've listed systemic endocrine effects. And it runs something like this. If you had remember I told you that benign neoplasms are almost invariably very well differentiated. It means they resemble the parental tissue. If you have a benign neoplasm arising from an endocrine, that is from a hormone-secreting tissue, it may well be so well differentiated that it mimics the adult tissue by secreting a particular hormone that ordinarily comes from that tissue. The difference, though, is that being autonomous and out of control of the body, this tumor will produce gobs of that hormone. And then the patient may present with a really tiny tumor somewhere may present with tremendous number of signs and symptoms due to an excess of a particular hormone. So in that regard, even a local benign neoplasm could produce systemic endocrine effects. Now, when we go over to the other side and we say, what do malignant neoplasms do? The first answer is very loudly, all of the above. Except now, instead of just sort of pressing the adjacent tissue, the malignant neoplasm, which is capable of invasion, can destroy that tissue by invading it, can compress, can violate ducts and other structures by invading them. Many malignant neoplasms grow much more rapidly. This is not a rule, but grow more rapidly than benign ones. So it really does all of the above with a vengeance. And also any given metastasis, and there can be dozens or hundreds of metastases, but any given metastasis can raise local hell wherever it happens to be. So you can see that, that all of the above is with a real exclamation point. Endocrine cancers can also secrete excess hormone, just like benign endocrine tumors. So any of those things that I listed up here you can see. Now there are a couple of other things. And this I want you to understand, at least at a conceptual level, that malignant neoplasms may be associated with some very, very significant systemic changes. And one of them that you may be familiar with from familial experience or friends of friends of friends is that frequently cancer patients will enter a phase of disease where they lose their appetites, they begin to lose weight, the weight comes piling off them, and they get weaker and weaker and weaker and just dwindle, and very often end up so weak that they are bedfast, and then the final event in their lives is pneumonia, which overtakes, typically will overtake a bedfast patient like that. We refer to that sort of wasting syndrome as cachexia. There's the spelling for it. That's a general term, but here we're talking about cancer cachexia. In other words, we're talking about a patient becoming emaciated and wasted because of cancer being there. When I was a kid in pathology, we used to teach that this was simply a caloric matter. You had a rapidly growing tumor which was eating up calories, competing with the host. The host lost the appetite along the way, and that was that. You just lost weight on behalf of the tumor. We now know that that's only a small part of the story, and this is a rather complex business related undoubtedly to cytokine secretion on the part of the tumor as it grows. But be aware that very often in patients with cancer you see this syndrome of cachexia. There are also, and this is an important general concept, I don't want you to get lost in the specifics, but there are other symptom complexes, that is syndromes, in patients with cancer that you cannot explain by local effects, mechanical effects, that they're not explainable on the basis of a predictable endocrine secretion. In other words, it's not that this is a cancer that we know is making insulin and therefore you're getting insulin symptoms. It's not that. But we find some very weird syndromes affecting a variety of organ systems that are due to the presence of the cancer, not mechanically, but the presence of the cancer in the body. And these are referred to as paraneoplastic syndromes. And I want you to get an idea of that concept, not the details of the various syndromes. They're important because, first of all, they may be a greater problem to the patient than the mechanical aspect of the tumor itself. And another thing is that the patient may present with the manifestations of a particular paraneoplastic syndrome at the time the cancer is still occult. And it behooves you to be able to recognize that, oh my goodness, this mixture of symptoms may mean whatever. Give you just a couple of examples and I'll leave the rest to your skimming reading. Don't try to memorize any of this stuff. But one of the commonest paraneoplastic syndromes is hypercalcemia, elevation in blood calcium. Now, You might think, if you're thinking mechanically, you think, well, cancer spreading to the bone will destroy bone and liberate calcium. That happens, but that's not a paraneoplastic syndrome. That's the mechanical effect. But some tumors will secrete a parathyroid-like hormone. In other words, they're not related to the parathyroid glands, a tumor of this or that, but it secretes something that has a parathyroid hormone-like activity and raises the serum calcium. That's not at all uncommon. Other examples of paraneoplastic syndromes are from what we call ectopic hormone production, where a particular tumor is producing a hormone that has no business coming from there. We see, for instance, lung tumors that produce corticotropin, in other words, a pituitary hormone that drives the adrenal gland. And this may produce all kinds of hell because the adrenal is overactive because of that ectopic hormone production. Some tumors provoke hypercoagulability. In other words, make the blood more likely to clot. We're going to study that in December. But suffice it to say, I have seen patients that present with deep leg vein clots, spontaneously. It's unusual in ambulatory patients, but they come in with clots in their leg veins, and after all the dust settles, it turns out they've got an internal cancer, pancreatic cancer, an ovarian cancer, what have you. And it's due to procoagulant substances associated with the tumor. Now, I'll drop it at this. And I'd suggest that you take a look at the appropriate pages in the book, and just to see the variety of paraneoplastic syndromes. Don't try and memorize them. Just be aware of that general concept of paraneoplastic syndromes. All right, one more matter before the quick picture show is a matter of nomenclature of neoplasms. And I want to emphasize that this is not a trivial matter. It may seem trivial to you, name the tumor, so what? This is very, very important because if we name the tumor precisely and accurately, it transmits a lot of information. In other words, as you learn more about oncology, if someone says it's such and such kind of tumor, this will bring up a little Rolodex card of a whole bunch of information. So it's important to be precise in the terminology, and you've got to become familiar with this. It's got to be just reflex with you. You'll use it throughout your career, and the time to learn it is right now because it's going to be on your exam this weekend. I promise you, it's that important. And what I want you to be able to do is take the description of a neoplasm. You don't even need a picture. Take a description of it and say, okay, with those elements, this is exactly how I'm going to name it. And you should be able to do this after you leave the room today, but certainly by this weekend, and it's very important to you throughout your career. There's a table in your book, I think it's on page 273 if I'm not wrong, that shows you a benign this and a malignant counterpart, a benign this and a malignant counterpart, and so forth. I don't want you to memorize that, but spend 30 seconds with that chart, and it will give you an idea of how we go about naming things. Now, basically, it's not rocket science. We name tumors on a basis of two things: the tissue of origin and whether it's benign or malignant. In other words, by looking at the neoplasm, and you'll be able to do this coming spring, you'll be able to decide its histogenesis, what tissue it springs from. That's an important part of the name, and we'll see this in just a moment. And then, depending on whether it's benign or malignant, we tack on a different suffix, and to kind of make a compound word transmits an awful lot of information. So learn how to do this. Now let's dive right in and talk about, first of all, epithelial neoplasms. Now again, an epithelium, you're going to become very familiar with this, is a sort of tissue that covers a surface like the epidermis, that lines the mouth or the GI tract, that lines cavities. By convention, we consider liver tissue to be epithelial. Kidney tissue, the tubules in particular, to be epithelial, and so forth. So we're talking about epithelial neoplasms. Now, the plot thickens a little bit. There are different kinds of epithelia, as you will learn. There are glandular epithelia, there are non-glandular epithelia, there's something we call transitional epithelium, etc. Don't worry about it. But I'll concentrate first on glandular epithelia. In other words, these are from structures. We're talking about tumors that arise from epithelial structures that are glandular or tubular or ductal. Those are we call glandular type. The root adeno means gland, and the suffix oma refers to a mass. And by convention, if we have a benign neoplasm of glandular epithelium, it is an adenoma. Okay? And that alone transmits a lot of information. That says to your listener, if you name something an adenoma, it says, well, it's epithelial. It isn't a connective tissue tumor, it's an epithelial tumor, and it's glandular, and it's benign. Good enough? Show you some adenomas. This is a cut through the adrenal gland. Now, the adrenal gland sits deep in the fat above the kidney, way in here, a few inches in here. It's about that big normally. And what I've done here is cut through the adrenal gland. This is a cut through the normal gland. The yellow part of the sandwich is the cortex that makes various steroid hormones, and this is the medulla that makes catecholamines, like epinephrine and so forth, right in that dark spot. Now, here we have a neoplasm. First of all, it's very well circumscribed. It just shelled out of there. So you'd say, well, it's probably benign, doesn't look invasive. I can tell you that under the microscope, this was perfectly differentiated. I mean, cell for cell, although they're arranged a little differently, they look like the cells here. And you can get a hint of that in that it's the same yellow sort of stuff comprising of which this is made. So this is an adenoma arising from the adrenal cortex. So we'd call it, give it the whole name, an adrenal cortical adenoma. Now the question is, well, how did that patient come in? He didn't say, Doc, I've got a walnut-sized mass in my suprarenal fat pad. I mean, it is obviously buried in there, and there's no way to feel it. The way this presented was because it was making an excess of hormone. In other words, this was a patient who was going on through his or her life and developed a series of symptoms. In this particular case, and I can't tell from looking at this, I know the history, this tumor was making gobs and gobs of aldosterone. And the patient came in with I won't bore you with it, but a syndrome relating to blood pressure and changes in certain serum electrolytes and so forth. And the smart physician said, ooh, put these things together. Something is making too much of an adrenal cortical hormone. Then it's simply a matter of imaging, finding out which side, out it comes, and you got a cure. Because that's perfectly benign, very well differentiated. Here's one for you. I have to explain this a little bit. This is a pancreas. It's been sliced, and the two halves are looking at you. This is what the normal pancreas parenchyma looks like. It's a lobular glandular tissue. And here's a marble. Very well circumscribed marble in the middle of it. This was benign. Can't tell that by looking at it exactly, but it's benign. And it arose from the islets of Langerhans. Now, with that in mind, how do you suppose this patient presented? Again, that's a little marble in the middle of the pancreas sitting way in there. How did that patient present, or why? Hypoglycemia. In other words, that tumor was producing insulin without regard to the needs of the body. And these patients, there are variations on this syndrome, but basically if they're not just eaten, their insulin level is high, their serum glucose goes down, and you get a variety of symptoms all the way to convulsions and coma. And that's the most dramatic part of this. And a cure is effected by removing that sort of thing. All right, here's another sort of adenoma, and we're going to talk about this in detail this afternoon, so I'm not going to belabor it now. But this is an adenoma arising from the lining of the colon, which is a glandular lining. So, and it's benign, it's a well-circumscribed, non-invasive thing. So this is a colonic adenoma. Sort of growing on a stem here. This is normal colonic mucosa that's sort of pulled out. What would be another name for that? Anyone have an idea? All right, polyp, sure. But I warn you, you got to be precise, because the term polyp is just a topographical term. Anything that hangs like a dingleberry off of a mucosal surface is a polyp. Now, some polyps are in fact neoplasms, like this one, but some are simply inflammatory masses. Some of you who have nasal allergies may have been told that you have nasal polyps. And it's things that sort of look like that up there, but they're not neoplasms. They're just bags of edema fluid and a few inflammatory cells. So anything that's off on a surface you call a polyp. Well, yeah, that's a polyp, but there are other kinds of polyps in the colon. They're not all adenomas. So if you want to be precise, you could say this is an adenomatous polyp, or simply a polyp. Some of them grow on stems like that. We call that a pedunculated adenoma. Some of them are sort of attached to the surface without much of a stem. There are a couple of little adenomas just budding right off the surface. These things are generally asymptomatic. It would take a hell of a big adenoma to produce any symptoms. Occasionally they're associated with a little odd called bleeding, but basically they're hidden there. The significance is some of these, given enough time, turn into cancer, and that's going to be the theme of our presentation this afternoon. So I won't belabor it at this point. All right, what about, and you can go back on that chart I gave you, the next step down, still on the left side, benign, non-glandular epithelia. This is a cartoon of a benign neoplasm of the lining of the bladder. Happens to be what we call a transitional epithelium. Now, very often these sorts of things grow out. I think this does a good job. It's a series of finger-like projections sort of pointing at you. And each one of these is a bit of stroma covered by a layer of neoplastic transitional epithelium. And we refer to these finger-like projections as papillae. So this becomes a papilloma. And this is a transition, happens because it's a transitional epithelium, it's a transitional cell papilloma. And just mention in passing that these can be asymptomatic, or these papillae break off a little bit and then you get some blood in the urine, hematuria. I'll show you a real life papilloma. These things present as little tiny bumps, very often in the oral mucosa or the back of the throat, the oropharynx. And this was one of them. It was about the size of a pea. And this is the normal squamous epithelium lining the oropharynx. And what this is a series of these finger-like projections growing out of this epithelium. We don't see the precise point of attachment. And each one of these is a little finger cut in cross-section covered by this squamous epithelium. Perfectly benign. So this would be called a squamous cell papilloma. These are, well, the variation in this theme on the skin surface is a common wart. And there are all sorts of variations in this, generally caused by one or another strain of the human papilloma virus, HPV. You'll hear about this constantly. But there is a papilloma. Now, one other variation on this theme. Sometimes it comes to pass that you get a neoplasm of glandular epithelium that grows in bubbles. In other words, the neoplastic epithelium lines the inner aspect of holes, which we call cysts. Technically, a cyst is a hollow space filled with fluid lined with an epithelium. And there are some neoplasms that grow as collections of multiple bubbles or cysts lined by this neoplastic glandular epithelium. And a good example of this is a fairly common set of benign neoplasms we see in the ovary. And we call these things, because they are multiple cysts, we call these cyst, one word, CYSTADENOMA. See how we, and here's what it would look like. Don't have a scale on there. Normal ovary is about the size of a, you know, small nut. This thing was about the size of a football. They can get big. The benignity of this would be suggested by the fact that the surface is perfectly smooth. I mean, whatever there is there, it's orderly, and it's lining that surface, and it's perfectly smooth. Cut into the thing, and you see its cystic character. These were filled with a mucinous material, which we washed away, but there's a cyst, and that's lined by benign glandular epithelium. There, and so forth. Many little daughter cysts. So that is an ovarian cystadenoma. See how we build the names? Now, with that much in mind, we go to the next step and say, what about malignant counterparts? Now, the rule here is if you have an epithelial neoplasm of any sort, and it is malignant, it is a carcinoma. So if the word carcinoma appears as any part of the name, you say to yourself, gee, this is epithelial and it is malignant. Transmit a lot of information with that. Then you add compound parts of it. If it's a glandular malignancy, what do you suppose you call it? Adenocarcinoma. If it's a squamous malignancy, squamous cell carcinoma, etc. I mean, and then you can throw on, you'll see in our reports, all sorts of things. Moderately well differentiated mucin-secreting adenocarcinoma. Well, that's put on some frosting on the cake, but the basic thing is that tells you that it's glandular and that it is malignant. So I'll show you some carcinomas quickly. That'll make about half of you cringe. That's just what the label says. The glands of the penis is largely replaced by this. I'll give you another few words. These are all words you'll learn to live with. We would refer to a neoplasm that's growing out like a mushroom here. We talk about it as fungating. Fungus, fungating. So this is a question.
Yeah, I was just wondering what distinguishes between a cyst and a cystadenoma. Cysts?
I'm sorry?
You can have an ovarian cyst, but what makes it?
Well, some cysts, let me give you a generic answer. Some cysts are not neoplasms. If you obstruct, for instance, a ductal structure, and something is secreting into it, and it's obstructed here, it'll become cystically dilated. It'll form a cyst. Other cysts happen to be the way they are because they are neoplasms. Okay? Well, at any rate, getting back to this, so this is a fungating neoplasm. Another word we use is exophytic, EXO meaning outward, PHYTIC, growing outward. Well, this is partly fungating, but this was infiltrating deeply. This is a highly malignant neoplasm, even though it's pretty well differentiated. And this was present in the inguinal lymph nodes at the time this happened. The covering of the glands is squamous epithelium, and this was a squamous cell carcinoma. Now, this illustrates something you'll learn is not uncommon, is that people have a great sense of denial. This thing didn't show up the Thursday night before he came into the doctor. This has been there many, many months. And people have all sorts of ways of explaining these things away and denying them and hoping they're not there tomorrow morning when they shower and so forth. But that's a highly advanced lesion. Here's for the other half. Now this one is also a squamous cell carcinoma. The labia are covered by squamous epithelium, and there it is. Now, that was sensed by the patient as a sore, kind of a sore there that didn't heal. It wasn't the mass that was exophytic, but this thing penetrated in about 1 centimeter or 2, and it was also present in the inguinal lymph nodes on that side. Squamous cell carcinoma. Here's one that we don't see much anymore, and I hope you never see one like this. This is a cervix, tubes and ovaries over here, and vagina here. And what should have been a nice cervix here is completely destroyed by this very, very advanced squamous cell carcinoma. The face of the cervix that juts into the vagina is covered by squamous epithelium. So many of these cancers are squamous. But remember I showed you the endocervix the other day that also has glandular lining. So we do see some adenocarcinomas there. But these are basically provoked by a number of strains of the human papillomavirus. It's a transmissible virus, and this is one of the bad outcomes. Now, I hope you'll never see, and you'll probably never see one quite this advanced if you practice in this country, because of the widespread use of pap smears. And we discussed that last time. You can apprehend this sort of thing when it's still in the in situ stage, or even earlier with dysplasia. You don't have to wait for this when this woman already had a foul, bloody discharge because of this terrible neoplasm. Well, let's go back in the GI tract. Up in the upper aerodigestive tract, the tongue, the lining of the mouth, the back of the throat, the larynx, and so forth, we commonly see squamous cell carcinomas. And this is a tongue that's been amputated and cut sagittally, and you can see this very deeply invasive mass. This was a squamous cell carcinoma arising out here. These oropharyngeal cancers are mostly related to smoking and drinking. And so histologically, this might look identical to the thing in the cervix, but it's got a different etiology and different behavior. But this was a very deeply invasive squamous cell carcinoma. Here's another one. This is a heavy smoker. And this is a larynx opened in the back. So the Adam's apple is sort of the front, and I spread it open, and there's a deeply ulcerating tumor there. This thing had been around for months and months and months and months. And at first, cancers don't necessarily cause pain. You know, unless they infiltrate nerves, they're not going to cause much pain. This guy had an irritative cough, and his voice changed, as you can imagine, with the vocal cord gradually being destroyed. But, you know, heavy smokers are used to being hoarse and coughing and so forth. And again, the denial kicks in, and this was a long neglected squamous cell carcinoma of the larynx. Take you down the esophagus now. The mouth is up there. This is the esophagus coming down in the stomach here. And you can see we've opened it up, and there's this roughened area. And in the cut surface there, you can see that the wall is thickened. This is a very advanced carcinoma. The lining of the esophagus is squamous, and this was a squamous cell carcinoma. These, as you can imagine, will produce some mechanical problems. Patients will have trouble swallowing. And there again, I've seen patients come in on strained baby food before they finally say uncle and decide that something might be wrong. And these are very hard to cure because of the fact that they are advanced and they're local metastases, if not distant metastases. We can also see adenocarcinomas in the esophagus because there are some glandular epithelium there that can also give rise to it. Now, if you look at that, I tell you this is a stomach that's been opened and washed. There's the esophagus up there. There's the duodenum coming off over here. If you look at that for a while, at first you might say, well, there's nothing wrong with that. But you'll notice that the normal fold pattern is ironed out here. It doesn't look so awful at first blush, but that is a diffusely infiltrative carcinoma. And what kind do you suppose it is, given that the stomach is a glandular lining? Adenocarcinoma. And these things are very subtle and asymptomatic until they're advanced. This was very advanced. This was metastatic in the liver already at the time it came. So they may not produce early symptoms at all. And an interesting wrinkle here is the incidence of this kind of tumor is very high in Japan, much higher than here. And it's largely an environmental thing because the descendants of Japanese who come here pick up our other Yankee problems. But this incident changes. But it's such a public health problem in Japan that they will screen for this sort of thing because there's nothing like this going to produce symptoms early on. So the only hope of getting it earlier is by population screening, and that's another matter for another time. Here's one that'll anticipate this afternoon. Getting down into the large intestine. This is actually in the first part of the large intestine over here, right where the small intestine enters, where the appendix comes off. This is the so-called cecum. And it's about, 3-4 inches in diameter. And here's a huge fungating neoplasm there. And it's a glandular lining, so it's an adenocarcinoma. Now, in terms of clinical presentation, this thing isn't as big as it is. It doesn't obstruct something that big, so the intestinal contents keep passing by. Doesn't cause any pain, at least at this stage. One of the things that happens with these is they bleed. You know, the passing traffic will erode the surface and they'll bleed. They'll ooze blood. Now, this is about 3 feet from the anus. Colon goes up here, across here, down here, does a little bit of a loop and goes out. And the fact is, by the time the blood goes from there to the anus, it's no longer red, it's black. The patient will be passing stools that, I mean, if he's losing enough blood, will be passing stools that perhaps look tarry. That's the epithet given to them. Something we call melena. Learn that word if you don't know it. M-E-L-E-N-A. Means black tarry stool. And patients will come in a couple of ways with this. They may say, if they're particularly observant, they look in the bowl before they flush, Doc, I got tarry stools, what's wrong? More than likely, and this is something you must always remember, you get a middle-aged or elderly patient comes in and said, I'm just pooped all the time, and you know, describes being easily fatigued and weak and so forth, and you take a look and they look kind of pale, and you do a hemoglobin, and you find they're terribly anemic, and it's from chronic occult blood loss like this. And colonic cancers on the right side are notorious for that. Get cancers all through the colon. This is one very close to the anus, which encircles the whole bowel now like a napkin ring. And will actually produce narrowing in the lumen, obviously has infiltrated the muscle of the wall, and that will produce a change in bowel habits. Or it will produce frank blood in the stools. It's close enough to the anus that if it bleeds, it's going to come out blood. That's referred to as hematochezia, H-E-M-A-T-O-C-H-E-Z-I-A. Hemato meaning blood. Chezia is a wonderful Greek word for meaning to go potty, roughly. So hematochezia is frank blood in the stool, which may be that. And again, people deny this. They say, oh, I've got hemorrhoids, and they buy preparation H and stick it up there for however long before they finally come in. And the important thing is, as we'll also point out this afternoon, is the survival and the prognosis is stage related. How far has it penetrated through the bowel wall? Is it in the regional lymph nodes and so forth? These are the important factors. All right, a couple of smokers' things. You can see about 50 pack years of stuff in that lung. And here is a mass obstructing a bronchus here. And this is the dilated bronchus full of mucopurulent exudate. Now, that's the tumor right there. And this patient presented, oh, he probably had a cough, but all smokers cough. Presented with repeated pneumonia. Kept coming in with episodes of pneumonia. It was always in the same place. And they finally tumbled to the fact that, well, he's got must have an obstructive lesion there. And there it was. Now, the bronchus is lined by a glandular type of epithelium. So there are adenocarcinomas in the lung. But notoriously, there can be metaplasia of the bronchus that goes on to not only metaplasia, but dysplasia and then cancer. And many of these are squamous cell carcinomas. So there's a relatively small one that produced repeated bouts of pneumonia. There's a larger one, just to show you what they can look like when they really get out of hand. Here's an interesting one. Close up here, trachea coming down here, bronchus here, and you see this little thing. This was a squamous cell carcinoma. And you say, well, why didn't they simply do a pneumonectomy, take off the bronchus here? You can live with one lung. Well, I'm doing a trick here. This was an autopsy specimen. And actually, this thing that looks small here had gone through the back of the bronchus. This is all neoplasm. It kind of encased the heart. It was hopeless from the get-go, a squamous cell carcinoma. All right, cystadenoma was the benign one, a nice smooth surface, and the inside of the cysts were lined with a nice smooth epithelium. Here's the malignant counterpart. You can see this time this is another ovarian neoplasm. It's malignant, so we call it cystadenocarcinoma. Not cystadenoma, but cystadenocarcinoma. The thing that would immediately tip us to say this isn't just a simple cystadenoma is the surface is no longer smooth like this everywhere. It's got a very furry-looking growth all over the surface. And the bubbles inside are filled with neoplasm growing from the lining of each bubble. In other words, many of these, you can see some bubbles or some cystic spaces, but many of the previously cystic spaces are filled with this rapidly growing neoplasm. So this is cystadenocarcinoma. I don't have an illustration of it, but you can imagine a papillary tumor being a papillary carcinoma. You could have a papilloma or a papillary carcinoma. So learn to handle these, the nomenclature here, as I say, quite by reflex. Now, let's switch away from epithelial. Question?
With the papillary benign ones, they kind of look finger-like.
Yeah.
How do you differentiate between that and malignant? I mean, they already kind of look like they're fuzzy.
There's a long answer to that, but I'll stroke my long beard and say it takes a lot of experience. And no, under the microscope, you would see not only growth in these fingers, but you'd see invasion. You'd also see more anaplasia cytologically. It's a combination of things, but that's a very good point. And sometimes it's a devilish problem. We see a lot of stuff growing out, and we've got to make multiple sections and see if any of it's invading. Yep. Now, getting away from epithelium, getting to non-epithelial tissues, what we call a supporting tissue or mesenchymal tissues like fat, fibrous tissue, smooth muscle, skeletal muscle, bone, cartilage. Those are the things we're talking about. The nomenclature becomes easy if you know a little Latin and Greek. If you have a benign tumor of fatty tissue, of adipose tissue, we call it a lipoma. Lipoma. If you have benign neoplasm of cartilaginous tissue, chondroma. Benign neoplasm of fibrous tissue, fibroma, et cetera, et cetera. As I say, I have to know a little Latin and Greek. The system here is if it's malignant, we don't call it a carcinoma because that's epithelial. If it's malignant and of a mesenchymal or supporting tissue, we call it a sarcoma. You've all heard these words, but now you have to use them precisely. So a malignant neoplasm of fatty tissue is a liposarcoma. A malignant neoplasm of cartilaginous tissue is a chondrosarcoma, and so forth. The interesting thing about these is they're not organ specific, because many organs have smooth muscle in the wall, many organs have cartilage, many places in the body have bone, and everything in the body practically has fibrous tissue. So you can see these tumors arising in a variety of places. Here's a strange one. This is an incidental autopsy finding. This guy died of something completely different and had no GI problems. This is a little piece of colon. I've opened it up here, mucous membrane here and here. And you look at that and you say, that's a wad of fatty tissue, about the size of maybe a big golf ball. How's that? Histologically, that was perfectly well differentiated. I couldn't tell it from normal fat cells in the center of that. That's just a big glob of adipose tissue. That's a lipoma. They do occur in the inner coats of the bowel, but it's quite rare. Where do you suppose the lipoma is more common? Well, where there's a lot of fatty tissue. They're very common subcutaneously. There may be some lipomas in this room. I could show you at least one. But they're not at all uncommon, and they're perfectly trivial on the whole. Even this big honker didn't produce any symptoms. All right, in the uterus, here's a uterus, and each one of these is what you would call a fibroid. But now I will give you the correct nomenclature. These tumors are benign. They arise from the muscle of the uterus, so they are myomas, M-Y-O meaning muscle. And because the particular kind of muscle, which you'll learn about is a smooth muscle, this is these are multiple leiomyomas. You with me? In the nomenclature? These can produce a variety of mechanical systems, hypermenorrhea, a big bulk in the pelvis, as you'd imagine, and some of them, many of them are asymptomatic, even at this size, believe it or not. Here is a malignancy of bone. Now, here's the X-ray. You can see this is what the bone should look like. It's very dense in here. There's obviously more bone being made. The outer membrane, the periosteum of the bone, has been lifted by something pushing out, and here it is. Here is the bone. Here is the bone-forming tumor here that is broken through the cortex and is out into the soft tissue. So this is a sarcoma of bone, osteosarcoma. This is, by and large, a tumor just in passing of growing bone, teenage kids, young adults, highly malignant, tends to metastasize early on to the lungs. Nothing is immune. Here is a tumor arising in the soft tissue of the thigh, very fleshy-looking tumor. It's derived from skeletal muscle, myosarcoma, but this time it isn't lio, it's rhabdo. You'll learn these details, but you should be able to look at a name like that and say, oh, this is a supporting tissue neoplasm of some sort. Yeah?
I was just wondering, osteosarcoma, how do you treat that? Do you remove the bone?
The osteosarcoma? Well, again, it's a long answer to that these days. And when I started out, all you could do was amputate and hope for the best. Now there are forms of chemotherapy and partial resection of the bone with insertion of other bone and so forth. There are a lot of nice fancy things they could do now. So it's nowhere near as dismal as it used to be, but it's a highly aggressive tumor. All right, quickly now, another kind of neoplasm. We talked about epithelial tissue, we talked about supporting or mesenchymal tissues. There are neoplasms of the lymphoid tissues, and by hematopoietic I mean blood-forming tissues. There are neoplasms of these. And here's where you get into some icky terminology. Neoplasms of the lymphoid tissues are referred to as lymphomas. And you would say, well, that sounds benign. Isn't that nice? Benign neoplasm of lymphocytes. Tain't so. There's no such thing as a benign lymphoma. We don't recognize them. If there are, we don't recognize them. So when you hear the word lymphoma, despite what it sounds like, that's a malignant neoplasm of lymphoid tissue. And similarly, well, I'll get to this, but leukemia refers to any situation really where the malignant cells, and they're usually blood-forming cells, are out en masse in the circulation. We refer to that as leukemia, white blood. The old German was weißes Blut, is the way it was described. All right, lymphomas are interesting. They may present as seemingly localized tumors with some local spread, but because lymphocytes, there's lymphoid tissue all over the body, and lymphocytes, you'll learn, move around the body, lymphomas frequently present as systemic diseases rather than localized. Sometimes localized, but very often systemic. This man came in This is an old photograph. And you see a general swelling in his neck here. You can see here's his clavicle. He's got a supraclavicular node there. He's got another supraclavicular node there. He noticed those, but his armpits were full of enlarged lymph nodes. By chest x-ray, his mediastinum was widened and full of lymph nodes. His abdomen was full of enlarged lymph nodes. He presented with a systemic disease. This was a widely disseminated lymphoma. Lymphoma can afflict many different lymphoid tissues in the body. This is the retroperitoneum. Here's a kidney. In other words, you're behind the peritoneal cavity. This is a mass of lymph nodes enlarged. They should be at the most pea size, and these are very big lymph nodes all matted together. This was malignant lymphoma in the retroperitoneum. Spleen, studded with nodules of malignant lymphocytes, if you will. Lymphoma in the spleen, even the kidneys, any organ can be infiltrated by lymphoma cells. And sometimes the marrow, the bone marrow, is overrun, and the malignant lymphocytes spill in great numbers into the bloodstream. Then you have a lymphocytic form of leukemia. Now, generically, leukemia refers to the presence of malignant hematopoietic or lymphoid elements in the circulation. So we see other forms of leukemia where the marrow, just the bone marrow itself, has gone bad, and you see malignant precursors of leukocytes, possibly red cells, a little bit more rarely, or even platelets. So it's malignancy of the marrow tissue with circulating, widely circulating malignant cells, infiltration of organs, and so forth. Well, just to wrap it up, I make the point that no tissue in the body is immune from neoplasms. We even see it in the central nervous system. We see neoplasms of the coverings of the brain, the so-called meninges, and typically a meningioma is benign. I throw this at you because the nomenclature is strange again. A glioma is actually a neoplasm arising in the brain tissue from the supporting cells called glial cells. Now, I've told you meningioma is benign. Glioma sounds benign. They're just varying degrees of malignancy. They're all bad. And I will show you why they are bad. Here's a brain with a glioma. Here's the normal side of the brain. And at first glance, well, you might see something's up, but basically, this is all glioma, and it's very hard to describe where it stops. This infiltrates diffusely, and there are glioma cells way out here and here and here. It's just so utterly diffuse that it's very difficult to handle. And the well-differentiated low-grade gliomas last a little longer. The patient lasts a little longer. The high-grade ones generally don't do so well. There's some promising interventions. This is the sort of thing that Senator Ted Kennedy has, although he looked good the other night, so he's still doing all right. But that's central nervous system. Then finally, there are mixed kinds of tumors. And these are befuddling and interesting. You can have tumors where you get a couple of different kinds of differentiation. For instance, we may see this common salivary gland tumor where you see glandular elements proliferating and cartilage, of all things. And those are referred to as mixed tumors of salivary gland, or more often now we call them pleomorphic adenomas, meaning a mixed form adenoma. There are such things as fibroadenomas, perfectly benign, fibrous and glandular. On the malignant side, there are such things as carcinosarcomas, two paths of differentiation, epithelial and glandular. Epithelial and supporting, both malignant. The ultimate here is a really mixed kind of tumor that arises from totipotential cells. And in these tumors, there are derivatives of all of the embryonic germ layers. It's just a marvelous thing. As you'd predict, they arise mostly in the gonads, but also in other tissues. I've seen them in mediastinum, I've seen them in the throat, but mostly gonadal. Bad news for the guys is most testicular teratomas are malignant, highly malignant. Good news for the women is ovarian teratomas are almost invariably benign. They're not uncommon. They're in your age group. They're usually an incidental finding, but they're endlessly fascinating. And I'll end by showing you a couple. There's a teratoma of the ovary. I've cut the ovary the size of a tennis ball. It should have a surface like that. I cut it open, and lo and behold, blonde hair. Now, in looking at this ovary under the microscope, it had not only hair follicles, but it had skin structures, sweat glands, sebaceous glands. It had cartilage, bronchial lining. It had something that looked like digestive tract, and it even had some brain tissue. I mean, these are marvelous mixtures. Most of them, as I say, are perfectly benign, and when we get one in the operating room and they bring it to us and we cut it open, we see hair, we say, wonderful. There. For some reason, the ovarian tumors most often are lined by skin-like structures, and they're sometimes called dermoids. But they've usually got a great mixture of stuff. Here's another one. What do you suppose this was, or these were? Teeth. That showed up as calcification on a pelvic film. And the last one, and I'm absolutely going to quit, is my favorite. This came out of an ovary. Looks like a chin with 5 o'clock shadow, and there's a nice dental arch there, and so forth. Well, that's what I've done is basically teased you into being interested in oncology, and you'll deal with it for the rest of your life now.